Our next body system is the respiratory system. I've got 4 lectures on this. It's the system itself is kind of straightforward, but the test tends to give people heartburn because there are calculations. The calculations are teeny numbers. It's like 2 divided by 1 times 4 or something like that. I mean, it's second grade arithmetic. It's not math, but it requires you to know where to put the 2, the 1, and the 4. That's the thing. It's the relationships between these various long volumes, how they add up to give you a different kind of capacity that you might be testing for, and so forth. Today we're just starting off with a quick introductory lecture, Introduction to the Respiratory System. Hello. There we go. The anatomy is of this, and you'll have all of this in the anatomy lab, being able to identify these parts. The nasal cavities, mouth, which is not officially part of the respiratory system, that's GI, but we can breathe through our mouth. A horse can't breathe through his mouth. He will suffocate if you block his nose off, because his airways are entirely separate. He's designed so that he can eat all the time and still breathe all the time. We have to stop breathing when we swallow. Soft palate, uvula, and epiglottis in the back of your throat, the pharynx and the larynx. And remember, the pronunciation is pharynx and larynx. It rhymes with lynx, not pharynx and larynx, as some people would like to say. YNX. Trachea, bronchi, bronchioles, and the alveoli. So let's look at it here. Nasal passages are fairly large. They lead up into the sinus cavities that we'll talk about later too. And they have ridges inside them called turbinates or conchi. The conchi are actually the bones that you may remember from A&P1 inside the nose that stick out on the sides. When they're covered with tissue, they become turbinates. And their point is when the air goes in, instead of shooting straight to the back of your lungs, containing dust and gnats and whatever, instead it has to bounce off these turbinates, and things stick to the sides of the turbinate so it doesn't make it into your lungs. The pharynx is the back of your throat, the part that you can see when you open your mouth. The pharynx. This is the oral cavity up here. This line actually goes a little too far. The pharynx is the back of your throat that you can see when you open your mouth. The larynx is down here. The larynx is actually I don't like the way these lines are pointed here. I'll see if I can fix that. The larynx is your voice box. That one's pointed pretty well here, okay? The larynx is the voice box area. It's hard and cartilaginous. Trachea is the single big tube. The bronchi are the bigger tubes, and then you get smaller and smaller and smaller bronchi as you get down toward the business end of the lungs. Your lung, overall, you have a right and a left lung. You have 3 lobes on the right and 2 lobes on the left. 3 on the right and 2 on the left. The lungs are in their own pleural cavity. They have a double layer. One is a parietal layer that sticks to the wall, and one is the visceral layer that sticks to the lung itself. And this forms that double sock that gives your lung the ability to move against the chest wall without abrading that tender lung material. And also the heart. It has the pericardium around it, and the lung has its double membrane here, so the heart can move around all it wants to while it beats and beats without abrading the lung tissue. Right below the lungs is the diaphragm. Here are the size of the tubes. The larynx up here is where the swallowing or the food goes through. So you have food going through right behind it in the esophagus, and in the larynx there's an opening that will steer the food into the esophagus or steer air down the trachea, and hopefully they don't get mixed up, otherwise you choke on something. The trachea, your big single tube, it's wrapped with cartilage rings to hold it open. So when you try to breathe out really hard, your airways don't collapse. They're held open. The right and left primary bronchi, one is a bronchus, two are bronchi, and then you have secondary, tertiary, and then smaller and smaller bronchi with less and less cartilaginous rings around them. Bronchioles is when the cartilage disappears altogether and you just have a little muscular tube that can open and close to control where the air goes. It's like a arteriole, except these are in the lungs, so these are bronchioles. The terminal bronchioles don't really open and close. They're what actually has the alveoli stuck on them. And the alveoli are these little sacs. Each one is an alveolus, but they come in these clusters of grapes with a hole in the middle so the air can go in and access all of the alveoli from inside that respiratory bronchiole. The lungs are like big sponges. They'll collapse if placed outside the chest cavity. They have a lot of rubber bands, and they're always trying to pull inward. Your chest wall is always trying to pull outward. And the balance between the two keeps your lungs open the amount that they're supposed to. If the lungs get too elastic and pull too hard, it's hard to breathe in. If they don't have enough elasticity and the chest wall expands too much, it's hard to breathe out. It's hard to push the air out. So what you're trying to get is exactly the right balance between that spongy elasticity and the compliance that allows them to stretch easily. The pleural cavity, or pleural space, is that space between the lung and the chest wall, defined by two layers of pleural membrane, and a tiny space in between that's filled with just enough fluid that it makes it slippery. But it also provides a vacuum seal so that when the chest wall pulls, the lung is pulled along with it because it's a vacuum. And therefore, when you expand your chest wall, it pulls your lungs open so you can breathe in. The pleural pressure is that slight negative pressure compared to the inside of the lungs. It's a vacuum that holds the pressure. Now we're going to see in the pulmonary section, instead of millimeters of mercury like we use in everything else, you use millimeters of mercury of pressure for your blood pressure and your, the heart, pumping pressure and all of this kind of stuff. We talk about millimeters of mercury. In respiratory physiology, they talk about centimeters of water. And it basically means the same thing. Pressure pushing on some of this fluid will push it up in a tube X number of millimeters or centimeters. You push up a barometer, you usually use mercury, and you push it up a certain number of millimeters mercury, and you can tell what your atmospheric pressure is. If you use centimeters of water, that works too. And the reason they use that is because blood is water. The pressure of the blood pressure in the top of the lungs is very small, and therefore you need just enough pressure to push the blood up to the top of the lungs so it can do its job up there. And so you're trying to raise the blood a certain number of centimeters, and since blood is essentially water, you're pushing centimeters of water to get the blood to go where it needs to go. For our purposes, they're not exactly the same. A centimeter of water is a little bit different than a unit of millimeter of mercury, but we're just going to say the same thing. If we change the pressure 1 centimeter of water, just assume we change it about a millimeter of mercury. That's going to be good enough for what we have to do. Transpulmonary pressure is the difference between the inside of the lung and the outside, trans. So the alveolar pressure versus the pressure in the pleural space. There's a little bit of difference. It has to be Lower in the pleural space, vacuum sealed to hold the lung open. If air moves into the pleural space, it will result in a pneumothorax, air in the chest. Okay? Of course, everything's in the thorax, but air in the chest, rather in the alveoli where it's supposed to be, and that is a collapsed lung. So here we have the bronchioles. The alveoli are tiny, they're microscopic on the outside. They're attached to all of these respiratory bronchioles on the end. Here's the trachea, the primary bronchi, secondary, tertiary, tiny bronchi, bronchioles, alveoli on the end. This whole area around here between the lung and the adjacent tissues, including the diaphragm, including the chest wall, that's the pleural cavity. That's the pleural space, and it is kept at a vacuum. There's your diaphragm under there. You get down to the area where exchange actually takes place, and it's just like in the circulatory system, it's the capillary beds. And capillaries are found wrapped like nets, like baskets around the alveoli. Here we have a bundle of grapes, the alveoli. In the middle, it looks like it's been scooped out with an ice cream scoop so that the air that comes in here will access all of the alveoli. And you have deoxygenated blood coming from the pulmonary artery down through the pulmonary arterioles, down to the capillary beds. It gets oxygenated and goes back to the venules and the veins. The pulmonary vein takes it back to the heart, oxygenated. We'll spend some time on that in the labs too, on that anatomy part. So the functions of each part, first of all, the nose, pharynx, and larynx. That, in other words, the upper respiratory zone. If you have an upper respiratory infection, it's in the nose, the back of your throat, or your voice box. You lose your voice and get a hacking cough up here, but not in your lungs. That's lower respiratory. Or a runny nose, sneezing, watery eyes. That's all upper respiratory. The job of the upper respiratory area is to filter the air, nasal hairs, and also the turbinates, so you filter out anything at least major so that it doesn't get sucked into your lungs. It warms the air to body temperature, and it moistens it to 100% relative humidity. It humidifies the air. Respiratory airways, the farther down, we're talking about the lower respiratory zone in this case, the trachea and the bronchi. Cartilage rings around these will keep the airways open even when you're pulling out. They're also going to continue to warm and filter and saturate with water. The linings are covered with goblet cells that make mucus, so you always have a thin layer of mucus on your airways so that anything that goes in there will stick to the side of your airway rather than getting sucked into your lungs. And these airways are ciliated. Not the trachea, not the larynx and the pharynx and stuff, but when you start getting down into the trachea and more specifically into the bronchi, you get these cilia lining the airways, and here we have the airways, and these are little tiny hair-like guys on the tops of the epithelial, the columnar epithelial cells, ciliated cells. See, these are pseudostratified. It looks like they're maybe stratified, but here this one has its nucleus up here. His nucleus is down here. He's long and skinny. He goes all the way up there. There are your cilia on top, and those cilia are tiny little hairs that wave like seagrass, and they move the mucus toward your mouth. So anything that gets stuck to the side of your airway moves upward and outward. It either moves into the back of your throat and you swallow it so that your stomach acids kill the bacteria or whatever, or you blow it out, you blow your nose or spit or something. So it's designed to keep your airways clean. One of the critical things that goes wrong with long-term smoking is it kills the cilia. If the cilia stop functioning, then the mucus builds up in there, it stays there and provides a perfect place for the bacteria to grow, and you develop a smoker's cough and chronic emphysema and chronic bronchitis from the infection that can live in there. The bronchioles, once you get past the bronchi, the bronchioles don't have cartilage. They are muscular, like arterioles, and they open and close to allow airflow. Now, not all of your lungs are open at the same time. You don't need all of your lung capacity when you're resting. You only need maybe a third of it. So parts of your lung that you don't ventilate deeply will simply close up, and you won't ventilate and you won't deliver blood to those because you don't want blood going someplace there's no oxygen. So these guys are subject to sympathetic stimulation. Beta-2 receptors in the lungs. Remember, beta-1 receptors squeeze your heart harder and make it beat faster? Those let in more calcium. That's what those guys do. Beta-2 receptors use GS proteins. If you remember, the GS makes cyclic AMP and it causes smooth muscle to relax. And therefore, when you start exercising, your sympathetic stimulation of your airways is to open them, to relax them, so you get more air going into your lungs during exercise. Bronchodilation. Parasympathetic stimulation, which is less important in the lungs, causes the opposite. It would cause bronchoconstriction. But the beta-2 receptors during exercise dilate your lungs. Now, the resistance to airflow in a healthy lung is very low. You don't feel yourself working to pull the air in and out. Now, if you're exercising hard, it becomes actually an effect. If you're really working to get the air to go in and out, you can feel the resistance going on in those airways. However, most of the time, the resistance is extremely low, especially down at the bronchioles, where you have so many millions and millions of them that total cross-section is very wide. Plenty of room for the air to move down at that level. Your greatest resistance you do have at rest is in the large bronchi, because they're large, but you don't have as many of them. So there's actually a little bit smaller cross-sectional area there. Now, during exercise, resistance can change because you're trying to move the air faster than the tubes can handle. Also, when you get sick, one of the main things that happen is you release histamine from your mast cells, and maybe from basophils too, and it causes the bronchioles to constrict, and you start wheezing. You have an asthma attack or an allergic reaction to pollen or something like that, and you start wheezing and find it hard to breathe. And even worse is this slow reactive substance of anaphylaxis, which is a ridiculous name for anything. They could have called it something else. But anyway, causes an anaphylactic reaction, which makes, people can suffocate and not be able to survive. Here's a chart that shows where the resistance is highest. It's at the larger bronchi, and it's lowest down at the terminal bronchioles, because you have so many of them. Very low resistance down there to airflow. Now, the respiratory bronchioles actually have alveoli stuck on them. So the terminal bronchiole is the last place where you're really going to resist, open and close, and let air go through. The terminal bronchiole has alveoli stuck on it. It will have occasionally individual alveoli, but mostly the end of it has those clusters of grapes on the end, the alveolar clusters. So here we have a terminal bronchiole that's got muscle. Here we have respiratory bronchioles with their like little individual alveoli starting to show up, and then their cluster on the end with the alveolar duct in the middle. The alveolus itself is a nice little round guy, simple squamous epithelial cells. What you want is the fastest, easiest exchange of oxygen and carbon dioxide that you can get. So you have, one simple squamous cell for your alveolus, one simple squamous cell for the capillary, and then a little basement membrane in here to give it some strength. And so you have a very short distance for oxygen and carbon dioxide to go back and forth. So your type 1 epithelial cells in the alveolus are simple squamous epithelial cells. And those are your just to allow the oxygen to transfer. Type 2 epithelial cells make a product called pulmonary surfactant, which we'll talk about in a second. You also have these little wandering macrophages wandering around in here. These little guys, macrophages, alveolar macrophage, they call them dust cells because they pick up dust and any other little things that may make it past your defenses and get into your lungs. So you have these macrophages wandering around in there, the type 2s making surfactant, and then mostly type 1 cells for gas exchange. Okay, so to get air in and out, you have to move. You have to expand and contract the lungs. Air doesn't just flow in and out by itself. You got to make the lungs bigger to suck the air in, and you got to make the lungs smaller to blow the air out. And moving the lungs involves a certain compliance of the lung tissue. Compliance of a vein makes it stretch easily so it can hold more blood during rest. Remember, those are your compliant blood vessels, that hold the extra blood. And lung compliance is how easy it is to open the airway. Now here's the calculation, and it looks terrible. This just says the delta volume, in other words, how much it changes, divided by the difference in pressure on the inside and outside, is your lung compliance number. So, if it's 2 millimeters inside and 1 millimeter outside, you have a difference of 1 millimeter of mercury or centimeter of water. So if changing it 1 centimeter of water gives you X a number of molecules of air move, then that is your lung compliance. Now, it could be the pressure in the alveoli compared to that in the pleural space. Because if I pull on my chest wall, it's going to change the pressure, inside and outside, and it's going to stretch those alveoli to a certain degree, and the volume's going to change. So, the difference in pressure. The other way to look at it is how much volume do you get if you change the pressure at your mouth, at the airway opening? If I change the pressure in my lung compared to out here, how much air moves? Okay, I put a little pressure on. How much pressure did I put and how much air moved? That's lung compliance. If I lower the pressure by 1 centimeter of water, a normal lung, about 1/5 of a liter of air goes in, about 200 milliliters per centimeter of water. That's a good number to memorize because you'll have a question. It'll say, okay, you drop your pleural pressure, your alveolar pressure, 4 centimeters of water. How much air is going to go in a healthy lung? 800 milliliters, because 4 times 200 is 800. Okay? So that is your normal lung compliance. 1 centimeter of water giving you 200 milliliters of air would give you a lung compliance of 800 milliliters of air per centimeter of water. Okay? That's just the way you would say it. And it's more simple than it sounds. I change it to centimeter of water, how much air moves? If a whole lot moves, my lungs are really compliant. If hardly any moves, my lungs are not compliant. What if I only got 10 mLs of air when I change 1 centimeter of water? Well, I'd have a very non-compliant lung. I'm going to have to pull really hard to get a breath in. Now, the elasticity of the lung is the opposite of compliance. Okay? How easy is it to stretch? Well, how elastic it is, if it's more elastic, it'll be less stretchable, right? If I double the number of rubber bands, it's going to be less compliant. It would take more effort to get air to go in. And your lung elasticity and the compliance of the lung have to balance perfectly. Because you got to breathe in and out. You can't just, breathe in and let the air stay there. What you want is a perfect balance of pull and push. So it takes almost no effort to breathe. So, elasticity counters compliance. If I have a disease that increases elasticity, if I have fibrosis of the lung and the elasticity goes way up, what does that do to lung compliance? It goes down. If elasticity is higher, lung compliance goes down. All right, it's that simple. Now, there are a couple of major features that make up your lung compliance or elasticity. The elastic properties of the lung itself, these are your rubber bands, the elastin and collagen fibers that are always trying to pull in. But the other thing is you have all those millions of alveoli, all of them have a little coating of water on the inside, because those are simple squamous epithelial cells. They can't live in dry air. They have a little layer of water on them. Okay? And what water does, when you have a sheet of water, it creates surface tension. Now, surface tension's interesting. The molecules of water are slightly magnetic because you've got the H2 and the O, and the ones down here are like one pole of a magnet, and the O is the other. And so when they align themselves, they kind of hold themselves together. Not very strong, but just a little bit. And it's what holds a raindrop together, so it doesn't just come down as a mist. It's what makes it so if you do a belly flop off a high dive, it hurts like heck. You go kablam when you hit the water, because the surface tension doesn't let you enter the water that quickly. It isn't soft at that velocity. I used to wonder how the really high divers, the Olympic, 10 meters or 9 meters or 12 meter, divers, how they practice, because they got to do belly flops sometimes before they get good at doing a dive. And if you did a belly flop from that height, it would be nearly lethal. Well, they put aerators in the water, and it puts bubbles up through the water, and it breaks the surface tension. So it's like landing in shaving cream. You go whoosh when you hit the water, instead of hitting a hard surface like that. Okay, well, that's enough about that. But the thing is, every alveolus has surface tension, and surface tension pulls. It makes a soap bubble pull. The pressure inside is a little higher than the outside because the surface tension pulls inward. So your lungs are always trying to collapse anyway because of their rubber bands, but now all the alveoli want to collapse too because they have surface tension in them. And in fact, this surface tension makes up more than half of your elastic recoil of your lungs. It's a very substantial amount of pull. So to counter that, we have to have the water in there for the cells to live. Nothing we can do about that. So we counter the surface tension by making what's called pulmonary surfactant or alveolar surfactant. Surfactant breaks up the surface tension. It has little tiny tails that stick up through the surface. It's like the bubbles in the swimming pool that I talked about. And it breaks the surface tension so that it doesn't pull as hard. And it reduces it by like a factor of 12 or something. It reduces it so much that you're able to breathe in easily. You don't have all that surface tension. Now, premature babies are born with immature type 2 epithelial cells, and they don't make pulmonary surfactant, or not enough of it. And you have to put them on a respirator because they can't inhale. They don't have enough lung power, muscle power around the lungs to breathe in on their own. So it reduces the surface tension big time, and it works even better when the alveolus gets smaller and would tend to pull even harder because the water molecules are closer together, because the surfactant molecules are closer together too. So they break up the surface tension even better. See, here we have, here's our little the surfactant molecule. Here's the surface of the water right about here, and they are breaking the surface tension. And when it gets smaller, surface tension would be higher, but you also have more surfactant molecules per cubic micrometer or whatever. And so at all ranges of inspiration, expiration, you're getting this breaking down of the surface tension. Okay, so our next lecture is going to be ventilation, how we actually get air to go in and out. And now you know the factors that we're going to have to overcome to get the lungs to expand or contract to cause the air to go in and go out. Very good.